Welcome to the deep dive. Today we're tackling a really common condition, gastroenteritis,
Right?
something I think pretty much everyone's had the misfortune of experiencing, and we're doing it by digging into a set of revision notes a listener actually sent us.
Yeah, exactly. So the plan is we'll break these notes down, pull out what you really need to know for revision, and, talk it through so it sticks.
We'll go through all the key sections.
Piece by piece. Definition, causes, complications,
Mhm.
the whole lot. Just trying to connect the dots from the material you shared.
Think of us as helping you extract the gold from these notes. We'll point out where maybe a memory hook or a practice question might be useful.
We'll focus just on what's in these notes, looking at the high-yield stuff for gastroenteritis specifically.
Okay, let's unpack this then, starting right at the basics.
Mm-hmm.
How do these notes define gastroenteritis?
Fundamentally, it's defined as inflammation of the gastrointestinal tract.
Okay.
So that involves both the stomach and the intestines.
And the typical symptoms listed.
The common ones are diarrhea, vomiting, abdominal pain, and sometimes you get a fever too.
So basically, an inflamed gut causing those pretty specific unpleasant symptoms. Simple enough start.
Yep.
Now, the causes. What does it say about the etiology? What's causing this inflammation?
Well, the main culprits listed are infectious agents.
Mm-hmm.
So that's things like viruses, Norovirus, Rotavirus are big ones.
Right.
Then bacteria like Salmonella, Campylobacter, and also parasites, Giardia, Cryptosporidium.
Wow, quite the rogues gallery.
It is. But the notes also mention it's not always an infection. There are non-infectious causes too.
Such as?
Things like food poisoning, sometimes that's about bacterial toxins rather than the bug itself infecting you. And reactions to medications can also trigger it.
Interesting distinction with the toxins. Okay,
Yeah.
so knowing the causes is one thing, but how do people typically get it? What are the risk factors mentioned?
The notes list some key ones. Poor sanitation and hygiene practices are right up there.
Makes sense.
Contaminated food or water, obviously. Close contact with someone who's already sick.
Especially in certain settings.
Exactly. Crowded living environments, think schools, cruise ships, nursing homes. And having a weakened immune system, the notes mention AIDS as an example, makes you more susceptible.
So if you're thinking about who's vulnerable or how it spreads, that list is gold. Maybe for revision, you could link those. Like picture a specific scenario for each one.
Yeah, that's a great way to make it stick. Connect it to something real.
Okay, we've got the what, the who, the where. Now, the how. Pathophysiology, what's actually going on inside the gut?
So according to the notes, the infectious agent or toxin gets into the GI tract,
Right.
and it irritates and inflames the lining, the mucosa.
Okay.
And this inflammation disrupts normal function. It leads to increased fluid secretion into the gut.
So more fluid going out.
Yeah, and at the same time, decreased absorption of fluid back into the body.
Ah, so it's getting hit from both sides.
Precisely. Plus, you often get altered bowel motility, things moving through too quickly or just differently. And that combination, that's what causes the symptoms.
The diarrhea, the vomiting, it's the direct result of those changes.
Exactly. The irritation translates directly into those specific symptoms because of the fluid shifts and motility changes.
Okay, that makes sense. But given those symptoms can be quite general, what else might be going on? What does it list under differential diagnosis?
This is a really important section. You got to rule other things out. The notes list, obviously other types of food poisoning,
Right.
but also chronic conditions like irritable bowel syndrome, IBS, or inflammatory bowel disease, IBD, and even things like viral hepatitis.
Okay, quite different underlying issues there. What about the other conditions to consider? That list looked quite long.
It is quite comprehensive, yeah. It includes traveler's diarrhea, which, is often a type of gastroenteritis, but the context is key.
Mm-hmm.
Then things that might surprise you: urinary tract infection, UTI, constipation, but with overflow diarrhea.
Right, where liquid goes around a blockage. Yeah.
Exactly. Gastritis, maybe from NSAIDs or alcohol. In pregnancy, things like hyperemesis gravidarum or even late-stage preeclampsia or eclampsia presenting unusually.
Wow.
And even Addison's disease, an endocrine issue.
That's a seriously broad list. So for revision, maybe grouping those mentally could help, like gut problems, things mimicking gut problems, systemic stuff.
Definitely. Clustering them helps you cover the bases when you're thinking through possibilities. It stops you getting tunnel vision.
Good tip. Okay, let's zoom out. Epidemiology. How common is this? Who gets it most often?
The notes stress it's very common in the UK, a big public health issue. It hits certain groups harder: children, the elderly, and the immunocompromised.
Back to those risk factors again.
Exactly. It ties together. Outbreaks are common in those crowded settings we mentioned. schools, hospitals, nursing homes.
And the scale? Did it give numbers?
Yeah, it mentioned around 17 million cases yearly in the UK.
17 million, that's huge.
It really is. It also points out some patterns. Bacterial cases are more common in summer. Viral infections account for maybe 30–40% of infectious cases overall. And Norovirus is the main viral culprit in adults, causing that winter vomiting.
Right.
And specific zoonotic infections, ones from animals like Campylobacter and Salmonella, they see annual occurrences.
Seeing those numbers, the seasonality, it helps frame the problem, doesn't it? And gives clues about likely causes at different times or in different settings.
Absolutely. It adds that crucial context.
So moving to what you actually see and hear from someone who's ill, the clinical features.
Yeah, the notes reiterate the main symptoms. Diarrhea, which can be watery or bloody.
Important distinction.
Very. Vomiting, abdominal pain, nausea, maybe a fever, and the big one, dehydration. It also stresses that severity and how long it lasts varies a lot depending on the specific cause.
And incubation periods, too, how quickly symptoms appear.
Yes, they vary significantly. The notes give rough timelines. Viruses often hit fast, maybe around a day. Bacterial ones, it varies. More could be hours for some like bacillary dysentery, up to maybe 4 days.
Right.
Parasites generally take longer, maybe 7 to 10 days.
Okay.
And it lists specific examples like Norovirus causing winter vomiting. It also makes a useful point about fever in adults.
What's that?
If an adult has a fever with gastroenteritis, it's more likely to suggest an invasive bacterial infection, whereas kids often get fever with it anyway.
That's a really handy clinical pointer. So assessment, how do you check someone over?
Standard stuff first. Check vital signs, do an abdominal exam. But the absolute key is assessing for dehydration.
How is that broken down?
The notes give stages. Mild might just be lassitude, maybe some postural hypotension, feeling dizzy when standing up.
Okay.
Moderate could involve apathy, being listless, and tachycardia, fast heart rate.
Right.
And severe dehydration is serious. Confusion, shock.
Okay, that assessment of dehydration is definitely high yield. Picturing those stages, mild to severe, and the signs for each. That's crucial revision.
Definitely. It directly tells you how urgently you need to act.
So, you've assessed them. You suspect gastroenteritis. How do you confirm it? Investigations.
Well, the notes emphasize that often the diagnosis is purely clinical, based on the story and the examination.
So you don't always need tests.
Not always, but there's a specific list of times when you should consider sending a stool sample for microscopy, culture, and sensitivity testing.
Okay, what are those triggers? This sounds like prime revision material.
It really is. You'd send a sample if the diarrhea is acute and painful, or if there's blood, mucus, or pus in it.
Right, those red flag stool features.
Exactly. Also, if the person is systemically unwell, showing signs of infection beyond the gut, or if they're immunocompromised.
Okay.
Other triggers include recent antibiotic use, or recent hospital admission, if you suspect food poisoning from a specific source, or recent travel outside Western Europe, North America, ISNZ.
Got it.
And also, if the diarrhea keeps coming back or just isn't getting better, if you're uncertain about the diagnosis or for infection control reasons like in an outbreak.
That's a really clear list. Definitely one to know when to investigate. Anything else mentioned?
Blood tests might be needed if someone's particularly unwell. Imaging is less common, maybe if you're worried about bowel distension or another complication.
And there was something about notification.
Yes, important point.
Yeah.
Dysentery and food poisoning are notifiable diseases by law in the UK. Labs often report positive findings, but clinicians also have a statutory duty to notify public health.
Good to know. Right, let's talk treatment, management. What did the notes say?
The core of general management is supportive care. So hydration is paramount, encouraging a balanced diet as they can tolerate it.
Fluids.
Pretty much.
Yeah.
Antibiotics for vomiting or antidiarrheal meds like loperamide can be considered, but cautiously.
And antibiotics.
Only for specific bacterial cases.
Yeah.
Confirmed or strongly suspected. Not routine at all.
Right.
Education is also big, preventing dehydration, good hygiene. And that practical point, exclusion from work or school for 48 hours after the last symptom.
That 48-hour rule is key.
Definitely. Advise seeking medical help if things aren't improving or worsening, and obviously hospitalization for severe cases or those with risk factors.
What about specifically in primary care?
Very similar focus. Assess dehydration level, educate the patient. Provide support and clear information. Advise on fluid intake, using oral rehydration solutions, ORS.
Okay.
Encourage gradual reintroduction of food. The notes specifically warn against routine use of certain drugs, like maybe anti-motility agents in some situations, and stress cautious antibiotic prescribing.
Hygiene advice, too.
Yeah, promote strict hand washing, careful laundry practices, follow those exclusion guidelines, and then make that judgment call about hospital admission.
What are the criteria for considering admission from primary care?
Severe vomiting, making oral fluids impossible, signs of sepsis or significant dehydration, but also other factors weigh in, like
Hmm.
not responding to initial advice, relevant travel history, being very young or very old, difficult living conditions, worrying symptoms, or other medications they take that might complicate things.
So it sounds like support, hydrate, educate, know when to test, know when to medicate cautiously, and know when to escalate to hospital.
That sums it up nicely based on these notes.
Okay. Prognosis. What's the usual outcome?
Generally good, thankfully. Most people get better within a few days to a week on their own.
That's reassuring.
But severe cases, especially with complications like dehydration, definitely need proper medical intervention. And again, the notes reiterate the higher risk in the very young, the elderly, and the immunocompromised.
It keeps coming back to those groups. Does it mention prevention again here?
Yes, it reinforces those practical steps. Cooking meat properly, washing salads and veg thoroughly, avoiding cross-contamination, separate boards for raw meat, wash everything well.
And hand hygiene.
Absolutely critical. Before food prep, after the toilet. The notes explicitly state effective hand washing prevents a huge number of cases. Simple but powerful.
Couldn't agree more. Okay, last big section, complications. What can go wrong?
The most common issues, especially in those vulnerable groups, are dehydration and electrolyte imbalance. Pretty straightforward consequences of fluid loss.
Right, but there are rarer, nastier ones.
Yes. The notes list hemolytic uremic syndrome, HUS, that affects kidneys and blood cells, often linked to E. coli 0157, and toxic megacolon, a dangerous dilation of the large bowel.
Serious.
Very. Then there are reactive complications that can pop up after the infection settles. Joint pain, skin issues, eye problems, often linked to specific bacteria like Campylobacter or Salmonella.
Post-infectious problems.
Exactly. Salmonella can also cause systemic invasion spreading beyond the gut. And Guillain-Barré syndrome, that nerve condition is mentioned, especially linked to Campylobacter.
GBS is a big one to remember post-Campylobacter.
Definitely. Other potential issues listed are malnutrition if it drags on, intractable diarrhea, problems absorbing medications, and rarer things like TTP, developing IBS, or lactose intolerance afterwards. It even notes inflammatory bowel disease can sometimes be triggered by certain gut infections. And the bottom line for severe cases is hospitalization, potential for shock, and rarely even death.
It really highlights that this common illness can have severe consequences. The notes also went into detail on specific infections, didn't they? Linking bugs to symptoms and timings.
Yes, that section is incredibly useful for revision. It gives specific examples,
Mm-hmm.
like E. coli often causing watery traveler's diarrhea, Giardiasis causing prolonged non-bloody diarrhea, maybe lasting weeks.
Okay.
Cholera, the classic, is massive, watery rice water stools, leading to rapid, severe dehydration.
Right.
Shigella often causes bloody diarrhea known as dysentery.
Right.
Staph aureus food poisoning, think rapid onset vomiting, often just hours after eating, sometimes linked to contaminated cooked rice left out.
The classic picnic scenario.
Kind of, yeah. Campylobacter often starts with flu-like symptoms, then cramps, fever, diarrhea that can be bloody, and that link to GBS. Bacillus cereus has two forms, one causing quick vomiting like Staph aureus, the other later diarrhea, also often linked to rice. Adenovirus tends to be a more gradual onset of bloody diarrhea over weeks.
That level of detail linking the bug to the type of diarrhea, the timing, associated features like fever or vomiting dominance, and specific complications like HUS or GBS is so valuable.
Absolutely. And the incubation periods really help differentiate.
What were the ranges given?
So vomiting within 1-6 hours strongly points to toxins from Staph aureus or Bacillus cereus.
Very quick.
Yeah. Salmonella or E. coli, maybe 12-48 hours. Shigella or Campylobacter, typically longer, 48-72 hours. And then parasites like Giardia or Bacillus, often around a week or even more.
It's fascinating how knowing that time frame gives you immediate clues about the likely culprit. This section feels tailor-made for creating a comparison table or flashcards.
Definitely. Match the bug to its typical story incubation, key symptoms, potential complications.
Okay, so we have really unpacked these notes on gastroenteritis. We've gone right through from the definition, causes, risks, what happens in the gut, the differentials, epidemiology, clinical picture, investigations, management, prognosis, and right through to those potential complications, all based directly on the listener's material.
And hopefully breaking it down like this, pulling out those key lists, when to investigate, criteria for admission, the specific bug details, and suggesting memory hooks makes it feel a bit less daunting for revision.
So, what's the big takeaway? Understanding gastroenteritis isn't just about the immediate symptoms, it's about the context, the likely cause, who's most at risk, and keeping those potential downstream effects and complications in mind, especially for vulnerable patients.
And maybe a final provocative thought for you to consider as you revise. How does knowing just one piece of information, like the incubation period, immediately shape your thinking? How does it help you predict the likely organism, anticipate the main symptoms like bloody versus watery diarrhea, and even flag potential complications, guiding your whole approach?
That's a great point. That one detail can unlock so much. We really encourage you to go back through these notes, maybe listen again, and focus on those specific lists and details. Use those memory techniques we talked about.
And if you are looking for more high-yield revision resources, particularly for the MSRA, check out passthemsra.com and freemsra.com.
A huge thank you to the listener for sharing their notes with us for this deep dive.
Yes, thank you. It was great material to work with.
We'll see you next time on the deep dive.